This one, the third and fourth, actually, I shouldn't say actually. I should have told this later only. It is not kept for many questions have not been asked from that portions. In fact, none actually, because this is usually this third and fourth one. I did it for actually to show it in the MQA purpose, the documentation purpose. Otherwise, because that's the portion that you always study, maybe from case management and homeotherapeutics always being repeated. And some of it's about the diagnostic procedures, the advanced diagnostic procedures, where the DNA, RNA is involved, that you are actually going to do. So I'm not sure whether I should do that for you, but we'll just go through screening and also immunology now. The other PPT maybe just a quick look, but for even exam orientation purpose, exam oriented, I do not want you to spend more time on those two PPTs. So the last one, as I told, evaluation and diagnosis, and the first thing in is that is disease screening. I'm not sure, have you heard of, I mean, you studied disease screening in detail or not? One second. When you learned so many of the diseases in practice of medicine case management, you should have or you would have heard the term screening. But exactly the terminology is used over there. I don't know whether you know or not. Excuse me. Yeah.
And they were from BBJ is written about your license application. Correct? Mazura has.
Yes, yes,
So
yes.
anyone person in charge?
Yeah, I am.
So
One second, one second.
what you see, what kind of business you're doing. Correct? Mr. Amon.
Huh? No, no, I'm Indian, international.
Amia, Amia Bow, which
He's the founder.
is about. Correct? Mazura Healthcare.
Yeah.
Correct? Correct?
Matsura Healthcare, yeah, yeah, Matsura Health.
So what you do here actually? It's
Actually,
a homeopathy.
I practice in homeopathy.
What is good homeopathy?
It's an alternative method of treatment. So, how do they do
What is the
I'm a doctor.
Okay.
So, the is a patient who came out here. So now I'm busy. I will be after 5.
Very well.
After 5 o'clock, I will be.
You buy the clothes?
Huh? No, 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 I will be there.
Idea. Very well. Okay. Is it like problem?
Like a disease treatment is there. Because of people, hypertension, my any condition, not surgical. Surgical is not involved and it is a surgery because we have a proper method. Otherwise, we try to give our medicine solutions.
So you're from here? Oh, which one?
Yeah.
Oh. I see.
All the different things you can't see.
Your treatment room?
Banner that I have kept.
Your treatment room? Your treatment room? You have, I mean, get ready or face or feel ready. You have only one room.
The second one was also the manner that we have to eat now. With other doctors.
Oh, it's under Newton, is it? Yeah, I just want to see, I mean, is it the application that you apply, is it same with the activities you are doing? Huh? Okay.
Can I know the process, sir?
Okay, already check, right? So I do that office, I do report, and consider approve your license. And I think within a 2 to 3, or within a month, I will take it. So if I do, so just give your person intention, they correctly accept the amount, then you can, because now it's for,
Okay with this?
for like, for medical incomes and health, so any health treatment or any health application, that you should only for the for
I'm sorry. In between, the person from the health department, I guess he came because as of now, we have got only our temporary license for 3 months. So he came, we knew that he would be coming, so he came for a check to know what we have applied for is the same thing. Are we practicing or not? Took some pictures, and now he will write a report, and we hopefully going to get 1 year duration license. So for that purpose, someone came in. So okay, we'll continue with the disease screening. So that's what I was saying. Screening is actually a process which is being done, or you might have learned in some other disease, TB screening, HIV screening, all those diseases, or even obesity, hypertension. Everywhere we use this term screening. So today we'll be learning what is screening actually in detail. It's a much more complicated process, not complicated, but so many calculations will be coming into it. So I'm not getting into the calculations per se, not that complicated also, but it is mathematics. So sometimes to do mathematics, to teach online mathematics online, it's not an easy task. We need to be together. We need to do or solve the problems together. You understand the technique, and then only it will be correctly understood. Otherwise, mathematics just by showing PPTs, I don't know how much I can teach you, or you can also learn, because none of our subjects, main subject is mathematics, except maybe for Vinod, the person from engineering background. Otherwise, no one is having that strong mathematical background. So I wouldn't be going into that calculations or the formulas into much detail, but just what are the some terms that is used and what is the meaning of those terms. That is what we are going to learn. So, screening, as the picture indicates, out of those 5 people, someone is being chosen out or screened out. So, we can say screening is actually like a sieve. Oh, by the way, I'm not getting any response from you after I came from break. You are hearing me, right? And also seeing the
Yes.
PPT. It's okay.
Yeah.
So screening as a sieve means you can see a group of people is moving through a sieve or a screening or a screen actually, and some are coming out as blue, but someone is coming out as yellow. So this person, the color it shows is he screened positive, and the blue are called as screen negative. So what this mean? So before I explain this, now this is something that we have learned in epidemiology also. In epidemiology, we learned that there is an iceberg of diseases. Where we only see the tip. We as clinicians, as doctors, when we are sitting to treat patients, we are seeing only this tip, the exposed part, which is actually the people who are actually diseased. They are having symptoms and they are coming for certain diagnosis, taking treatment, etc. But then the huge population is actually submerged in that water, the underneath, and this is the place or the population on which an epidemiologist had to be concentrated with, because the epidemiologists, they want to find out the prevalence of a disease in a population, and not everyone in a population will be having that disease at that moment. They may be in a pre-pathogenetic level, or the symptom has not come up up to now, it is in a latent stage or pre-symptomatic stage, non-diagnosed. So this is the hidden burden or a submerged portion, and the epidemiologist is more interested in this. Actually, when we do this epidemiology, we always say it is to find out how the diseases are getting transmitted, who are the people, what are the different ways, and why we do that to prevent the disease occurrence. So to do that prevention, rather than, it is not easy once the disease appeared and then you go do the prevention. There are prevention levels at that level also. The secondary, tertiary level of prevention comes over there, but the most important level of prevention is actually the primary or the primordial one, and that is happening actually in this area, the submerged portion. So epidemiologists, they always want to find methods by which they can prevent disease reaching into a higher level or this clinical or that tip level, and they try to solve the problem from here itself. So for this thing, we have to do something called as screening test. When people actually comes in this tip, when they are actually diseased, a patient is coming to you and you are having a doubt whether this patient is having TB, and you are going to send the patient for certain by uh, this lab test. It can even include from a routine blood examination and also sputum microscopy or even chest x-ray. That is what you are going to send the patient for, and this is what we call as diagnostic test. But then if we want to find out the person whether he is having tuberculosis in a group of people, uh, they are not patients, actually we are going to a school, and then we need to find out whether how many students or whether there are any students who are having TB. Then for all these people or students, we are not going to write do chest X-ray, do sputum microscopy, do then what is that routine blood examination. We are not going to write all these tests, but we'll be selecting one or two very inexpensive type of test which can give us a clue whether these people are having any disease. Any, they may be testing positive, they may be showing the disease, or they may not be testing positive also. So we find out certain tests which are very inexpensive and which we can easily do it in a group. Like for some example, and this screening test that usually done among a group of people, not one person, a group of people, and we go usually as a part of health campaign. We can go to some malls and all and do this type of screening. But when we go to malls and do that test we take, it should be inexpensive because we are going to do it on a lot number of people, so we can't have an expensive test for that. And also it should be something which can be done very easily. For example, you are supposing to do a screening test for breast cancer. And screening test for breast cancer, what are the tests that is possible? One is the breast self examination, or then physical examination by the physician who is sitting over there, and then the confirmatory will be a mammogram. But when you're going to do this, this is not applicable in case of a screening test, because you can't give or assure that much privacy which is required in this screening test to the people who are attending that this breast cancer screening. It is not that much privacy is not possible, And then the confirmatory test will be mammogram, which is going to be very expensive. So doing such a screening test for finding out people who are having breast cancer, it's not easy. But then if you want to find out the risk of developing stroke, or the people who may develop stroke in future, and you want to screen out those people, so the simple most technique for that is pressure. Like the people who are having hypertension, they are the people who have more chances of developing stroke. So you go with a simple BP apparatus in a mall, you can get to know the people with high pressure. And then you can give them necessary lifestyle modification, because that's a lifestyle disease. You can say a necessary lifestyle modification, or just in case if it is very high, some medication. According to the situation, you can do. So checking BP, it doesn't take much time, much resource, and it is very inexpensive. It is not invasive type. And then the benefits you are going to get is huge. You get to know the people who are having hypertension, and not only this one, stroke. You can even prevent development of any cardiovascular diseases also. So that is the basic principle of screening. You select certain uh, uh, diagnostic test, screening test itself, to differentiate whether the apparently healthy looking people means these are these group of people, the submerged one, they don't have any symptoms. So a group of people who are apparently looking healthy, but one or the two in that may be actually in a disease process stage. So from those apparently healthy looking people, you are going to introduce some few tests, very inexpensive, not so invasive, not getting into their privacy, and trying to find out whether do have their disease or not. And when they have their disease, you have to send those people for a diagnostic test. That's the second process. But the first one, this is the basic idea of screening. So when you do screening, a group of apparently healthy looking people are going through a test, a sieve, and then some are tested negative after, even after that test, the hypertension that you checked, they are not having hypertension, so they are screen negative. But one of it, you get that he's having a hypertension, so he becomes screen positive, and you notice this person, you give him a special class or something, or special notice, and ask him to come to your clinic or go to some other diagnostic area to do further tests according what it may be, to know whether actually he is having such a disease or not. So screening test, it detect the potential health disorders or diseases in people who do not have any symptoms of disease. Because if the people are having symptoms, they will wait for 1 or 2 days, and they will may try some home remedy, herbal remedy, and if it is not reducing, then immediately according to the severity, they are going to come to your clinic or any doctor's clinic, and they are going for diagnostic. It is the people who don't have any symptoms, they think that they are healthy. I mean, we all think, including me, will think, unless I have any symptom, I think that okay, I'm completely healthy, and then we don't go for this test. It is for those people the screening tests are meant to be. So its goal is to detect early the disease, and we are surveilling so that we can reduce the development of risk of disease, to detect early and to treat most effectively. So if I'm earlier knowing that I have such a tendency, or I have a BP, so that I may develop into a stroke or something, or even my there is hyperglycemia for me. So even now, if it is not diabetes mellitus, but still hyperglycemia is there, so that I take a control on my diet, my body activities, so that diabetes don't develop. So that is the main idea. So once the diabetes have developed, then maybe I have to take a lifelong anti-diabetics, or any anti-glycemics, I think what they call, or anti-diabetic remedies. But if I'm getting to know even before by some screening test and doing my necessary lifestyle modification, I can even maybe avoid or at least postpone for years the development of the disease. So, screening, it is actually for the detection, early detection, not just detection, the early detection of disease, any precursors of disease, anything that is even before the main disease, some precancerous stage, if it's a cancer, precancerous lesion, or any susceptibility, even that we could know whether I do have a chance of developing such a disease. It is done in people who do not show any signs of diseases. So the presumptive identification of those who probably have disease from those who do not have by means of rapidly applied test. Rapidly applied test. It should be rapidly. If a person, I mean, a group of people are coming to you for a screening test, and for one person itself, if it is taking 30 minutes, in a campaign that you have arranged from 8 to 5 p.m., how many people you are going to do? So whatever test you do, it should be rapidly done, non-invasive, not that much invading to their privacy, and also inexpensive ones. And always remember that it is done in healthy individuals, people who don't have symptoms. People who have symptoms, we do diagnostic tests for them, the confirmatory test. And this one, those who don't have disease, we are actually doing screening tests for them. So what is the benefit of doing screening? Why do we need to do screening? So what I already told is to detect the disease early so that we can prevent its complications or even its development or postpone. But when we say it in scientific terms, the advantage of screening is actually we get a lead time. So lead time is actually when we are going to see this graph, the graph you see from the starting point there is an onset of disease. And onset of disease, it is actually the when we remember the natural history of disease, the pre-pathogenic phase or the just the pathogenic it have entered, the disease have entered, but it is still lurking inside our body. The symptom have not yet come. And a screening test is always usually done for chronic type of diseases, not the acute one. It is usually done for the chronic diseases because acute one means then 1 or 2 days they are going to produce the symptoms. But we already told screening test we are doing in apparently healthy people uh, who don't have any symptoms. So it is usually the chronic diseases we are doing the screening test for. So imagine the first in this section is biological onset of disease. So disease is being originating, and at this stage, no one will be able to diagnose whether that patient is having a disease or not. So, for example, one patient, we get to know that he is having lung cancer, but it is not that that morning lung cancer suddenly developed in him. The process actually might have started 10 years or 5 years before. The process have actually started in his body, but then it took a slow time to develop the symptoms. So the biological onset happened here, but we are not able to diagnose the disease. uh, but after a certain period, you see the second arrow, it shows that we can diagnose or we can detect, not diagnose, we detect the disease by screening. This type is possible. But if we are not screening that person, then it will take actually the third arrow, the time gap between the first and the third one, for the person to develop symptoms. And when the symptoms develop, then also the patient will, all human beings will be like, just wait, what is happening? Whether it's serious, whether I need to go, he Googles sometime, then wait for some time, take some home remedy, herbal remedy, natural things, try to change something. And then if it is not standing within his hands, then he feel like to go to a doctor. And then he goes to a doctor who is going to diagnose the condition. So this gap, especially between, so when the actual diagnosis would have happened would be in between symptoms and the diagnosis. Otherwise the person is never going to diagnose. That is the usual. If the screening test is not being done, a disease will be diagnosed only in its normal process, the where the diagnosis is there. And once that diagnosis happens means the person has already developed symptoms. But when we do screening, we are actually making an advantage of this lead time, the time taken for the disease to develop, to diagnose, that is being reduced. Like we actually diagnose the disease very early, not diagnose, detect. I mean, I usually out of practice interchange, but when we are sticking with that topic, we have to stick with that correct term itself. I'll say you why it is not called as diagnosis, why we have to say detect. I'll say you later. But anyway, here, um, if we are going to do some test to detect whether the person is having a disease or a chance of developing a disease, and if it was cancer and we were able to detect this person is having some type of precancerous lesion or anything, or some x-ray changes that showed that some cavitation is appearing, or some lymphadenopathy, lymph nodes are, especially the mediastinal or the axillary lymph nodes are enlarged, which can give us a clue, oh, if this person might be going towards a cancerous condition. So even before the symptoms arise, we get to know, and then we can go for the treatment so that we will make a profit in that lead time. We get to recognize the disease condition earlier, and then we give the necessary treatment. So this is the scientific term that is used, usually asks for MCQ. The advantage gained by screening is actually lead time. Uh, Screening programs work better where the time lag between the disease onset and its final critical point are sufficiently long, which means the diseases should be of a chronic disease nature, not an acute one. If, like cholera, today you had food poisoning or the contaminated water, and what we learned cholera in last class was the incubation period can be anywhere less than 24 hours to 5 days. So today you had it, and tomorrow you are going to have the symptoms of cholera, most probably. There is no need to do a screening test for that. So always that gap should be very high, the disease onset and the diagnostic period. So that much beneficial, and if we could diagnose it earlier or detect it earlier. So what is the difference between screening and diagnostic tests? Screening, first thing, we do it in asymptomatic people, and diagnostic, we do it in people who are having some symptoms. Screening is always done in a large group of people, and diagnostic is done in that single patient who is having the disease. And screening, it can be, this is the one another most important thing, screening is less accurate, and that is why I changed the term. Like whenever I was saying diagnosing actual, no, detecting, though we interchangeably use correct term whenever we are using screening test, because it is less accurate. It is always detecting, it is not diagnosing. When we are diagnosing, we are confirmed by doing, when we take the case taking itself, we come to know, okay, if it is a rheumatoid patient, the type of the pain, and if he's having some physical changes, the small joints, the contractures, and from that itself we will understand, okay, the patient is having RA, rheumatoid arthritis, but still we will send this patient for the antibody testing. uh, I think it is the RA body, rheumatoid arthritis body, and also ANCA, ANCA, that, no, not ANCA, CPC, some crystalloid is the, which is used as a diagnostic, confirmatory diagnostic test for RA. So even though I get this clue from case taking, I still send the patient for X-ray or blood examination to confirm that he is having RA itself. So the report I get from the, it is accurate. If they say it is the, means it is the. In some type of cancers, they may not be able to differentiate. They may not be able to diagnose. That is the, because it may be very less changes that might have happened. But usually by diagnostics thing or diagnostic procedure, we can be sure it is accurate. And once it come like that, we are sure that this person will be having such a disease. In case of doubt, some doubt is there, then we can go for a second lab there is a possibility that some mistake have happened in the first lab, but the second lab also shows a positive result, means then definitely the patient is having such a complaint. But in case of screening, it is less accurate. We cannot be sure that this person whom we tested positive is going to have a disease. We cannot be sure. He may have disease, he may not have disease. It depends. So the screening test is always less accurate. It cannot be conclusive. So if it is less accurate, means it is not conclusive. We get the screening test positive. We cannot say, okay, the screening test is positive, so this patient is diabetes mellitus. We cannot say. We get this thing, some clue that there is a hyperglycemia. Then we ask the patient to go and do a proper uh, uh, blood sugar test, the fasting blood sugar, or the GTT test, oral glucose tolerance test, and then we come into the conclusion. Okay, he's a diabetic patient. So that is the main difference between screening and diagnostic. Diagnostic, we get the correct information, which is accurate. We can conclude whether the person is having that disease or not, but not in screening. It is not accurate. It is not conclusive. And screening is less expensive, and diagnostic is more expensive because it is done one by one and one to one, and also all the tests are going to be expensive when compared to screening in case of diagnostic test. And in screening, when we get the report, we are not going to start treatment because we are not sure whether this person is actually having the disease or not. There is only a probability, high probability. So we can't start a treatment. But in diagnostic test, once it is positive, we are going to start the treatment. Not we, the allopathic people. For us to start the treatment, we don't need the diagnostic report per se. And the initiative for the screening test, it comes from the investigator, because we are going to the mass, we are going to a group of people who don't show any symptoms, and the initiative comes from us. But here the initiative is coming from the patient. Then uses of screening we can use for the case detection, control of disease, for research and also educational purpose. Then there are two types of screening. There is a prescriptive screening and prospective screening. These two words can be used for asked for an MCQ. So prescriptive screening is that screening which is done for patients' own benefit. For example, a patient is coming to you in your clinic, and you just do weight, body weight checking, or his BP being analyzed. So this is for the benefit of the people. That is prescriptive screening. And prospective screening is to protect other people. For example, when immigrants are coming, like when I was coming over here, I had to give a medical report which showed that I don't have such diseases. So this was mainly done so that no migrant from other country will bring a disease to this country. So that is a prospective screening. Here, the screening, I had to go through the screening test uh, to make sure that I'm not bringing any disease to this country. And here, the screening was done for the benefit of others. Screening of immigrants from infectious diseases. So that's the difference between prescriptive. Prescriptive, the patient itself or that concerned person itself is getting benefited. He will get to know whether he's having cancer or whatever, and then he gets benefited. But prospective is like he may be getting benefited, or maybe I don't know. But the main target is to protect the other people. The best example will be done in case of immigrants when they are landing. Then what type of screenings test can be done? Screening can be mass screening. As I told you, a group of people, we go to the mall and we do the test. It can be like a subgroup like of children or college going. So college we can select, or then we can select a group of people involved in the same occupation. So then we go to that factory. So like that we can do a mass screening. Then, or we can go for a high risk or selective screenings. High risk or selective screening, as the term indicates, the people who are in high risk of developing that disease, you select only those people. For example, HIV or hepatitis B, and you want to do the screening test not in all the people, but only those who are sexual workers, or also those people who are using mm, drug drug injectors. So you're going to only that group. They are the high risk group of developing this HIV or hepatitis B, and then you are doing the screening test only in them. That is a high risk of selective screening. And one example from there is to recognize cancer cervix. Cancer cervix is mostly seen in women belonging to low socioeconomic condition, and also multiparous women, multisexual partner women. So you go to those people actually, rather than going to the whole population. Cancer cervix you can never find in a virgin woman or a young woman. So there is no need of doing a screening and waste her time or your time and even the little amount in that. Just find out the people who are at high risk and then do that screening. So that is high risk or selective screening. And then there is multiphasic screening. Multiphasic means different things will be involved. Like the people are coming for the screening. Even if you do a single this one BP checking, even that is a screening test. But at that time, you are thinking like anyway we are sitting over here, so we can take a weighing scale also, just measure their body weight. And then if you are taking a measuring scale for the measuring the height of the person, and you take the height, so you calculate BMI of the patient. Then there is someone to make a small puncture in the skin of the person to take some blood to know whether there is sugar, I mean diabetes, not diabetes, blood glucose or not. So you are doing a lot of tests together. You are doing calculating the BMI. You are taking for the glucose level. You are doing the also along with that BP. So hypertension you are doing for that. Then you are analyzing the weight and also the height of the person. So a lot, and apart from this, if you're going to give a questionnaire also, do you have the habit of smoking, alcohol, blah, blah, blah things. So a lot, 5 or 6 methods have come together. So that is multiphasic screening, application of 2 or more screening tests in combination to a large number of people at one time. And this is actually very expensive. Then we can do opportunistic screening, like people are coming for some purpose. Uh, what is that? Yeah, the pregnant ladies. The pregnant ladies, when they are in a doubt that they are pregnant or not, or the first confirmation, they are coming to the ANC clinic, they will be immediately sent for the STI investigations. All the hepatitis B, VDRL, syphilis comes under VDRL itself, I think. Then HIV, they will be sending it. So that's like an opportunistic screening. Likewise, a person who is tested for tuberculosis, immediately his blood will be taken to, or he will be asked to go do the testing for HIV. So that is opportunistic. The person is actually coming to the clinic for some other purpose, but then we are doing some other screening test. So that is, we are using that opportunity to find out another test, another disease he may be having or he may not be. So that is opportunistic screening. The other one is systematic. Forget about it. You just remember the mass, high risk, multiphasic, and opportunity screening. Then, what are the criteria for a successful screening test? For a screening test to be successful, we need two things, that is, criteria for disease and also criteria for test. Criteria for disease is this disease should be present in that population. There is no meaning that a very rare disease in this world. Um, which is can someone say me a very rare disease? Yeah, one disease is there which is called as CJD, or Jacobson Creutzfeldt disease. Creutzfeldt Jacobson disease, which is a neurological disorder. Actually, it's very rare to find out. 1 in 1 lakh or something you will get. There is no meaning. One day you keep a health campaign to find out CJD patients in the world. I mean, in the world also, it's very difficult to get in a mall. So the disease, what you're going to, for what you are going to do the screening test, it should be present in that population, and not just present. It should be present in a large, good number. There should be a high burden, and it should be a high public health concern. Or else, why should you waste your money, your time, your resources? Why to waste for that? And when if you find out, so the criteria has not finished. The third important criteria is, when you do the screening, there should be some intervention, and that should improve the outcome also. Like if you discover a patient is having a particular disease, a treatment should be there, and that treatment when given, he should be improving of his outcome. Otherwise, what is the need? We A person who might have got to know that he's having a particular disease 10 years later, and he's now knowing 10 years before he's having a particular disease, or he may develop into that disease, and then there is no treatment given, then what is the use? So there should be a treatment that could be given for this person, and also that treatment should have a positive outcome. There is no treatment, or even if you give the treatment, the person is going to die in 2 years. What is the use of finding it out earlier? So that is another criteria for the disease. There should be some intervention, and also it should be having a positive outcome. And we should know the natural history of disease, how it is developing. Without knowing that, we shouldn't do that. Then what is the criteria for the test? The test should be reliable, valid, simple, inexpensive, very safe, acceptable, cost effective, and exit strategy. But however, the most when we say about the criteria for the test, three criteria are important. One is reliability, acceptability, and also validity. These are the three important criteria out of all these what we told: reliability, validity, and acceptability. So reliability, it's another word, is repeatability, reducibility, or precision, which means when one person did that test, the, the result was positive, and when another person do that test in the same person, the result should be positive. That is reliable. It's not that when you did it, the BP was 140, and when someone else did it, it became 120. It shouldn't be like that. So it should be repeatable. When one person did it, it was 140, another person did it, it is 140 itself. That is reliable. It should be repeatable. A person is, when the test is repeated, we should get the same results. And if there is some variability, if it is a variability, the variability is possible at three levels. One is observer level. Observer level, it can be intra-observer or inter-observer. Intra-observer in the sense, just suppose I was testing the BP, and maybe I have to use this spectacles. And morning when I tested the patient's BP, at that time I used the specs. So I got an accurate value. Then after some time I am repeating the thing, but at that time I forgot to keep the spectacles and it is not correctly viewable. So I'm going to change the value. I mean, it is possible that I'm not able to read. That is intra-observer. Within the observer itself, I had some problem. That is what. It can be inter-observer. Inter-observer means I tested 140, my friend tested it as 150. That is in between. In between the observers, there is a variation that is happening. So it is possible. The observer variation is possible. The variability happening from the observer side, which is within the observer itself at different stages due to different reasons, or between two observers. Or it can be subject variation, and that can be a biological, especially in case of hypertension. There is a subject variation. If you remember the physiology, the BP, the normal BP varies according to the time of the day. It is less in morning, then towards noon it may increase, evening it is reducing. So, and also according to the body posture, when lying down it will be reduced, when sitting up or standing it will be increased. So BP in itself has got a biological variation by itself, not by any persons, by itself it is varying. And one moment when the person is actually extremely anxious, he is going to attend an interview or exam, his BP sometimes may be shot up. So that's just the anxiety being shown. So that unreliability, non-reproducibility can happen due to some biological reason within the subject, within the patient, or some technical method, the faulty BP apparatus. So this non-reproducible results or unreliability can happen at three levels, and there are methods actually how we have to solve that. I'm not getting into that details. This much will do for you. Then it should be acceptable. That I already told you in the example. It shouldn't be painful, unsafe, invasive, discomforting, embarrassing, and socially or beliefs that is not accepted. Don't do something that the patient wouldn't like to do. Then it should be valid. Valid in the sense the test should be able to distinguish the people who has disease from those who doesn't have. And for that validity, we give another um, three parameters to calculate or to know whether the test is valid or not. Actually, there are four. I'm not going into yield actually. We'll just concentrate with these three parameters: sensitivity, specificity, and predictive value. And in the screening, actually, it is what you need to know: what is sensitivity, specificity, predictive value. Predictive value, there is positive predictive value and also negative predictive value. So before we go into this sensitivity and specificity, we need to know some other terms like true positive, false positive, true negative, and false negative. So true positive. Now we told that when we are doing a screening test, the person may be tested positive. And after he is tested positive, we are definitely going to send him to diagnostic test. And then here you may ask, if we are going to send him to diagnostic test, why we do the screening test even? And the thing is to reduce the burden. Actually, we have 100 people and 100 people are not showing disease. And if we are going to do diagnostic test in them, how much cost it would be costing us? It will be too much. But when we do some inexpensive test and we find out of this 100 people, 20 are showing something that is positive, and you send only this 20 people for the diagnostic test, you are making a good utilization of resources. You are not simply sending other 80 people who will be testing negative, and then you are simply wasting money for them. But not like that. Some people in that 80 also may be diseased. We'll come to that. But anyway, for now, the true positive, that means now, see this as two words itself. In the English, it's two words. So, see this as two words itself. So, positive means someone who had tested positive in screening. And then you do, when they tested positive in the screening, doesn't finish over there, you have to confirm it. So, for that, you send the person for the diagnostic test. And in the diagnostic test, if the person is confirmed that he is having the disease, it is called as true positive. So the person was tested positive in the screening, and when diagnostic test was done, he was truly diagnosed. So that becomes true positive, which means this person who was tested positive in the screening test is actually having disease. That is true positive. When we say that he is positive via a screening test, we do the diagnostic test and we confirm that he is actually or truly positive. So then what will be true negative? When we do a test and when we find out that he is negative, he doesn't have test, and if we are going to do a diagnostic test for that person and he is truly negative, he doesn't have that disease, is called as true negative. So if a test was like this, truly, some tests we do, we get the people true positives. Then it is very what is that profitable for us. I mean, well utilization of all our resources. We do the test by screening, and they all are tested positive. Okay, well and good. And some people we say that they are tested negative and they don't have any disease. Well and good. That's also is okay. But as you know, the world never goes such black and white. We have gray shades. So the gray shade is actually the false positive and false negative. And what that means, false positive, which means they were tested positive and then they were sent for diagnostic, and diagnostic procedure told that they are not diseased. They were falsely told as positive during screening, and that is a problem. So false positive, you did the screening test, they were detected positive in the screening test, but then you send the people for the diagnostic test, and in diagnostic they find out they don't have disease. So in a way, if we see, it is a positive thing for the patient actually. He was told that he is having, suppose AIDS. He was told that during screening test he was having AIDS, and then he was tensed. He felt like his life, all life has gone, and then he go for the confirmatory test or the diagnostic test, and he understands it is actually false. He is not having AIDS. He will be mentally relieved, yes, but the financial burden that the health sector had to take it, that was too much, because we simply had to do diagnostic procedure for a negative patient just because the screening test told he is positive. So those are the false positive. They are healthy people, they don't have the disease, but during the screening test they were told they are as sick people. And the vice versa will be false negative. They are actually they were tested negative, but when they were done with the diagnostic test, they were confirmed that they are actually sick. I mean, they are having disease. It is not that they are negative. So it's the same HIV being applied over here. We do some screening test. The person, we find out that he's with the screening test came negative, and suppose we are not sending this patient for a diagnostic procedure. Just imagine like that. So we do a test. We saw that this person is HIV, not HIV negative. The screening test for HIV tested negative. So we say, okay, you don't have HIV. You go to on your own way. Imagine that person is actually HIV. Imagine, because we already told the screening tests are not confirmatory. So if he is actually HIV positive, the person, he might be, imagine that person contracted HIV because of his promiscuous life or multiple sexual partners. So he know about his history, and he feels like, okay, I'm HIV negative, or I don't have any STI, which means he can continue his high risk sexual behavior like that. And when he is HIV positive, we already saw in the AIDS disease, he can be actually transmitting the disease. So, though we saved money because not doing diagnostic test in him, we are causing huge problem to the health sector, to the population, because this person is going to now spread the disease to a large population. So up to now there is no screening test present that is 100 percentage testing the true positive or the true negative. It will be always some 80 to 90 percentage or 90 to 95 percentage. We need to consider which disease we are studying, and then analyze how much percentage of uh, what is that, uh, sensitivity or specificity we need. Okay, that for that I have to go what is sensitivity. So anyway, these are the terms. True positive, they are screen positive, plus they are diagnosed as positive. True negative, they are tested negative and also diagnostic test told that they are negative. False positive, screening tests showed that they are positive, but diagnostic tests told that they are false positive because that they don't have any disease. They were falsely told they are positive. Then false negative, the screening test told that they are negative, but when done diagnostic test in them, they were told they were falsely negative, that they do have the disease. They were told that they don't have disease, but it's not true. It is false. They are having actually the disease, the false negative. Now we go to the term sensitivity. So what is sensitivity? So sensitivity is the ability of a disease to correctly classify an individual as the disease. So we need to correctly identify among a group of people. When we say this people, so it is mainly related to true positive. How many people we are saying true positive? Uh, how many people we are able to identify as truly positive? For example, if you are doing a test in 100 people, and in 100 people, if you are going to find out 90 people who are screening positive, and suppose it is suppose only supposing is possible. So 90 people out of those 100, you tested them to be positive. And if 90 people, when we do the diagnostic test, they are tested positive, that means we are able to identify that much people who are actually diseased. So sensitivity means ability to correctly diagnose the true positive people or truly diseased people. And the formula will be sensitivity is equal to A by A plus C. For this, we have to go through a chart like this. So we do for 2 into 2 column. So here it is the screening test, the test people who tested positive. And here it is the screening report, the people who tested negative. And then these are the people who are actually diseased and who are not diseased. So when we do the test, true positive means they should be testing positive and also they should have the disease. So in case of sensitivity, we are going to diagnose or correctly, not diagnose, correctly detect these true positives as maximum possible. So our formula will be sensitivity is equal to, because we are going to find out the true positives, it will be true positives divided by the total number of, because we are going to find out the true positive means the diseased people, the denominator should be the total number of diseased people. So it will be true positive divided by true positive plus false negative, or you can see the same column having A, B, C, D. So it will be A divided by A plus C. I will never say you to learn this formula. Much for that only I told we need to be together, do the mathematical calculation, etc. But this is the basic idea. And I will never say you to study, even if you are studying the formula, I will never say you to study A divided by A plus C, because if you are going to do this and this ABCD, though it is told that it should be named like this ABCD itself, they can change the terminology. I mean, they can put alphabet X, Y, Z, W, X, Y, Z. So then how about studying A by A plus C? And if it is for exam time, the questions are actually twisted. They change the columns. They will bring disease to this side and test 2 over here in the position, which means the terminologies will change. You can draw a table and see if you change the position of test and disease, interchange the position, then it will no longer will remain the same. It will change. So never, even if you are learning, don't learn A by A plus C. Always learn true positive divided by true positive plus false negative. And how this game is sensitivity, you are going to correctly identify the number of people who are having disease, which means you are going to identify the true positive, which becomes the numerator, and the denominator should be the total number of people who are diseased, and that will be the column down, that is true positive plus false negative. So sensitivity is that it is the ability of a test or screening test to correctly identify an individual as diseased. The probability of being test positive when the disease is present. And then the second term is specificity. If sensitivity is about finding about the true positive, specificity should be about finding about the true negative. So to identify those people who doesn't have disease. So ability of a test to correctly classify an individual as disease free is called as the test specificity, or the probability of being test negative when the disease is absent. So the formula will be the same thing. We are going to find out the true negative. So true negative will become the numerator. And because the total population is non-diseased, the denominator will be false positive divided by true negative. Or if it is correctly termed A by A, B, C, D, then this will be the formula. So sensitivity, ability to correctly identify people who are having disease, the true positives. And specificity, it is the ability of a screening test to find out who are truly negative. And as I already told, there is no screening test in this world which is 100 percentage sensitivity or 100 percentage specificity. In an ideal world, it should be that thing. When we say 100 percentage sensitivity means even if we diagnose 80 people, 80 people as a screen positive, which and that means 100% sensitivity means all these 80 people when they are going to do a confirmatory test, they should be diagnosed positive, but it is not possible. There will be some uh, discrepancy always there. No test, as I told, no test has been there which is 100% sensitivity or 100% specificity. So even when we say 80% sensitivity, it is possible that not all the 80 people we diagnosed or we detected as positive are going to have disease. Some is not going to have. They are going to be actually false positives. So then if you ask me why do we do, the benefits, though these negatives are there, the benefits are far better than nothing at all. So that is the main reason why we do. Then we have this positive predictive value. Positive predictive value is when I told that you did a test and 80 people were diagnosed, sorry, were detected positive or were screened positive. And ideally, if it is 100% sensitivity, what we are expecting is these 80 people will be diagnosed as a disease persons itself in an ideal world. But it won't be true, as I already told. It will be only maybe 60 people out of this 80 are actually truly positive. The 20 were false positive. I'm just saying one random number. So the positive predictive value is you got a value or your screening test is the and you have found out your sensitivity is this much. How much you are sure that the person you diagnosed or person you detected to be positive is actually positive? That is actually positive predictive value. You are making a prediction. When you say this person is positive or screen positive, how much you are sure that he is actually truly positive? That gives the positive predictive value. So it is the percentage of patients with a positive test who actually have the disease, the probability the patient having disease when test is positive. We need to know that value also, how much you are sure, not just you correctly identify which is sensitivity, but how much you are sure they are actually positive also. That is positive predictive value. And when we do the calculation for positive predictive value, because this is also finding out the positivity or the true positivity, the formula will be, it's the same for positive predictive value. It is TP, that is true positive, that will be the numerator. But here, the total population is being considered. Total population in a sense, all those who resulted positive. Not, it is not taken column wise. It is not taken column wise, but we take the population or the denominator row wise. That is PPV. And NPV, the same concept vice versa. You are going to find out how many people we told negative are actually negative itself. Even when we do the diagnostic test, how many of them are actually negative. So here also The true negative will be coming as the numerator, and the denominator will be coming row wise, all the people who were tested negative. So if it is column wise, that is sensitivity and specificity. If it is row wise, it is PPV and NPV. Sensitivity to find out the true positive persons from among all the diseased persons. Specificity to find out the true negative persons among all the uh, non-diseased persons. And PPV to be confirmed or to say how much sure we are the people who we say as true positive is actually having the disease. And likewise NPV, the number of people whom we say are tested negative in screening test are actually negative. So that is the concept of this screening. It's only this much that you have to learn. You just need to know what is the term meaning, what is true positive, true negative, false negative, what is sensitivity, what is specificity, and what is predictive value, the positive predictive value and negative predictive value. If you have any doubt in this, you can ask to me now, because all the other topics, as I told, it's not that important. It is the screening which is very important. Can I go forward with the topic?
Yeah.
If you have any doubt, you can ask me later. So this is about the screening. The next PPT is, let's open it. The next one is actually immunology. I'm not going to into its detail because we have already done this in the last semester. I hope you remember. It's just because immunology is important, I thought of repeating it again as much as you hear. You're seeing the PPT, right?
Yes.
Okay. So in the second section, that is the immunology. So yeah, these are the four sections. This is screening we did, and then immunology. So immunology, this was the immune system is actually to protect the host from pathogens while minimizing damage to self tissue. And it was given importance only after to the 19th century. And if there is a dysfunction or deficiency of immune response, it results in many diseases. The immune system, is being classified into two: the innate immune response and adaptive or acquired immune response. Innate means by birth, something that has been they got by birth, and it provides immediate protection, but it is not specific. Adaptive is the which is developed throughout the lifetime. It takes more time, but it is specific to that particular pathogen, and it gives a long lasting protection. So immunity we can divide into innate immunity, something we get by our birth, and adaptive immunity through the life process or whatever changes we face through or the disease we have. This adaptive immunity is divided into natural immunity and artificial immunity. Natural immunity and artificial immunity can again be classified into passive immunity and active immunity. In case of active immunity, which is natural, it means an infection should come. For example, I developed measles, a disease. Measles as a disease came to me, and then my body is going to produce antibodies against that, which means that is an adaptive immunity. It is naturally because that disease came to me naturally, and then I develop antibodies. And passive immunity or passive natural is actually the antibodies are coming to my body, but in a natural way, like from mothers. We know from mothers, IgA and IgG and IgA. This IgA, it comes via breast milk, IgG and IgM via this mother, the blood. Among that, it is IgG that is transferring via blood, the placenta. IgG is via placenta. So IgG and IgA antibody from mother can enter into a baby. IgG via the placenta and IgA via breast milk. So if antibody is entering my body, so and how the antibody is produced, my immune system is not producing that antibody. It is producing it is not produced actually, it is ready-madely produced in someone else's body and it is entering in a natural process. So that is the entry of the um, maternal antibody to the baby. It's also actually natural type of immunity. In the artificial one, we are going to induce this artificially. So active will be immunization. Active part of artificial will be we are going to immunize, which means I will be or the baby will be given MMR vaccine. So it will be having that measles, mumps and rubella. So the child is actually not contracting any disease, any of this disease naturally from the environment. He is being artificially inducing this via an immunization or a vaccine, and then his body is producing antibody. That is active immunization. And passive immunization, ready-made injection of the antibody, especially done in cases of rabies, etc. Then, regarding the innate immune system, uh, so the innate immune system is something that is born, or which we are born with. It is the first line of defense, and it depends on genetic and constitutional makeup, like based on our geneticity and also the nourishment we have, the constitution we have. And innate immune system, it is non-specific. It acts within minutes. And some of the things that which is coming underneath is anatomical barriers. All our skin, the sweat, and the sebum, everything will come under that. Some type of phagocytic cells like dendritic cells, macrophages, neutrophils comes under that. Then soluble molecules, especially the complement system, and some natural killer cells. These are the innate defenses which are present in almost all the human beings. So the physiological barriers or the anatomical barriers, as we told, that the skin, the highly keratinized skin of the skin, keratinized cells of the skin, it can prevent colonization by microorganisms. Then the sebaceous glands, it produces certain sebum which can repel water and microorganism. Sweat, which contain lysozyme, which is actually containing um, many of the enzymes that can destroy bacteria. Then the mucous membrane in our body, all the mucous membrane, it is painted with IgA. So that can kill a lot of microorganisms. The cilia and the respiratory tract, hydrochloric acid in the GIT, they also can keep away a lot of microorganisms. And then the commensal bacteria, because two bacteria come together, then there will be a fight between them for space and also for nutrition. So then these bacteria may also kill the microbial bacteria. So these are the innate mechanism, but definitely some many of the microorganisms may be killed from our body in this manner. We never even know. But sometimes, apart from all these mechanisms, some microorganism will be able to enter our body, and then if it happens, other type of immune mechanisms like all the phagocytic cells, what we told, will come into action. The dendritic cells, the macrophages, neutrophils, etc., will come into action and do the process of phagocytosis. I have not put it because you know that. And then the other second important, and still these phagocytic cells did their phagocytosis. Still, if it is not able to solve the problem, another thing that can come is the complement system. So complement system, it is a actually a cascade mechanism, we can say, uh, in which actually it starts with one particular enzyme, actually a protein which is produced in the liver, and then as like the coagulation cascade, one enzyme, it will be converted into another, then that into another one, and a huge step is followed. A lot of chemicals or cytokines are produced, like about 20 regulated functionally linked proteins are produced, and this will eliminate the pathogens. So in the complement system, it is a very complicated thing actually. Just remember there are three pathways: alternative pathway, classical pathway, and lectin pathway. That will do, no need to go into much detail. Then this is a video which explains about the innate immunity, the complement mechanism. You can watch. Then we have other type of cells, that is mast cells and basophils, which are mostly important in allergic disorders. Why I kept over here is because later we have to do hypersensitivity type 1 reaction, and hypersensitivity type 1 is actually allergic disorders where mast cells and basophils play a very important role. So these cells are mostly important in allergic disorders. Mast cells are actually seen in skin and gut, whereas basophils, which is a type of WBC, it is actually seen in the circulation. And the importance is the mast cells and the basophils inside them, inside their body, a lot of enzymes or preformed enzymes are present within certain bags or vesicle in which already some enzymes are present. So once it is break open, all the enzymes will come out and can cause massive destruction. So this is a mast cell actually. So you can see a lot of vesicles. If something is happening, the mast cell break open means the vesicles will release all these chemicals. One of the chemical is histamine, and there are so many others: leukotrienes, prostaglandins, so many other. If you take the test book, at least remember histamines, which will be released, and this histamine will can produce various changes in the body, and that is actually responsible for the allergy. We see at that time. Then we have the natural killer cells. These are cells which are similar to lymphocytes, and it is against tumors and viruses also. And the difference between lymphocytes and NK cells: lymphocytes are the one which are involved in the adaptive immunity. The T lymphocytes and the B lymphocytes. So the difference between NK cells and lymphocytes are the lymphocytes are actually having some immunological memory. Some of it you might be remembering, it will be converted into memory cells. So that memory cells or keeping in memory, NK cells don't have that ability. Only morphologically they are similar to that of lymphocytes. And this is more towards killing or destroying tumors and also viruses. They are very important in the sense nowadays some researchers are going so that these NK cells could be used to treat the tumors or the cancer. That is why NK cells are given importance. Then going towards the adaptive immunity, if the innate immunity fails to provide effective protection, the adaptive immunity comes into action. It has got exquisite specificity, which means if an antibody is produced against chickenpox, then that antibody is acting against chickenpox virus only. Not like that. If the chickenpox virus was entering through my nose or mouth, the IgA which was present in the mucosal membrane, they will be giving equal uh, obstruction to that chickenpox. But when, because it is the innate immunity, it is not specific. Even if it is chickenpox or the measles virus or any other virus, they are going to give equal protection or equal obstruction to this bacteria or the viruses. But adaptive immunity means if an antibody is produced in my body against chickenpox virus, then this antibody will be active only against chickenpox virus, not any other viruses. It's not going to act against measles virus. That is why it is called as, it is extremely specific, highly adaptive, because it can a large number of antibodies could be formed against whichever antigen that is going to enter our body. And they do have the ability of memorizing, or that once the infection came, they will be keeping some cells to keep it in their memory. So the second time come, their action is highly activated. That immunological memory is present only in case of adaptive immunity, not of innate immunity. And adaptive immunity, we have two types. One is the humoral immunity, and another one is the cellular immunity. Humoral immunity means here the antibody, humoral or antibody, which is produced by the B lymphocytes. And the cell mediated immunity, or the CMI, it is actually by the T lymphocytes. It releases cytokines and kill the target cells. So this is in short, the table is about the immunity, innate immunity or acquired immunity. Innate immunity, we saw that the skin barriers are the sebum, sweat-like secretion, phagocytes, dendritic cells, NK cells, reticuloendothelial cells, then inflammatory process, NK cells, complement and interferons. And in acquired one, we divided into two, the humoral and the cell-mediated. Humoral, which is done by the B cells. Actually, the B cells, a part of it will be converted into memory cells. Vast majority will be converted into plasma cell, which are larger in size than B cells, and they release the antibody or the immunoglobulin. There are five types of immunoglobulin: IgG, A, M, E, and D. And in cell mediated, we have the T cells. We have three type of T cells: the T helper cells, the T killer cells, and the T suppressor cells. And another one is T memory cells. So some part of the T cells will be converted into memory cells as like B cells. So we have memory cells in both humoral immunity and also cell mediated immunity. Then the structures involved in the adaptive immunity, mainly it is the lymphoid organ, primary and secondary. Primary lymphoid organ will be bone marrow and thymus. So it is in the bone marrow, the T cells and the B cells, T lymphocytes and B cells are deriving. And B cells derive from the bone marrow and they mature in the bone marrow itself, whereas the T cells, they develop, or they are formed, not develop, they are formed in the bone marrow, but then they undergo maturation process in thymus. So it is the bone marrow and thymus which are the primary lymphoid organs. And secondary lymphoid organs are spleen, lymph nodes, mucosa associated lymphoid tissue, which is seen in the GIT. Now starting with the humoral immunity or the B lymphocytes. The B lymphocytes which are formed in the bone marrow and they produces the immunoglobulin. And before the immunoglobulin is produced, they undergo a complex process which is called as clonal expansion, rapid proliferation, etc. I have not gone into detail, but there is a video in YouTube where you can watch what is happening, because the process of maturation, the clonal expansion, the receptor formation in B cells is very complicated. So you can watch this video. Just for your information, usually no questions, exam-based questions will come from this part. We can ask about humoral-based immunity. So then you can mention about it's the B cells that is being produced, then the immunoglobulin and what they do. That's it. Nothing like the mechanism. Then the immunoglobulin, the 5-immunoglobulin, which is produced by the B cells. IgG, it is the most important one and large quantity one, 8 to 16 gram per liter, and it is the one transported across placenta. And IgA, it is seen in the mucosal surface and present in breast milk. I don't want you to remember this value, but other words that I have given in red, keep that in your memory. Then IgM, it is the first formed immunoglobulin. If you remember, when an infection comes, the first antibody formed will be IgM. Then later it will be converted into IgM, IgG, etc., etc. So it is the first antibody that is produced, and IgE, which is seen associated with mast cells or basophils. So it is very important in allergic diseases and parasitic infection. And IgD, it is not much detected also, function is unknown. About the cellular immunity, the T lymphocytes are responsible for that, and it is against virus, fungi, and intracellular bacteria. The bacteria which is present inside the cell. Because a humoral immunity, the term is humoral or blood or antibody, which means that antibody can kill only those organisms which are present in the circulation, in the blood. But we know there are viruses, HIV virus. It is seen inside the cell. We saw that in HIV. And then tuberculosis, Mycobacterium tuberculosis. It is also intracellular. Inside the macrophage, it is seen. It won't be seen that easily in the circulation. So, how to destroy these organisms? The organisms or the pathogens that is circulating in the blood, we can kill via antibody. But what to do with those organisms which are seen inside the cell? For that antibody is not going to go inside the cell and kill those. For that, we need the cellular immunity. So it is not that the B cell and actually the B cells to produce antibody, they need an activation from one of the T cell, that is the T helper cell. So T helper cell should be produced, only then B lymphocytes will be activated to produce antibodies. So the thing is, though we classify adaptive immunity into humoral and cellular, should understand these are not two separate entities. One is acting one way, another is another way. No. For B lymphocytes to produce antibodies, the action or that stimulation should come from the T lymphocytes. The T helper cells should come and activate it. So they are in a collaboration action actually. And also the activity is antibodies when they kill the pathogens circulating in the blood. There are pathogens which can live inside the cell, which is killed by the T lymphocytes. So this process, I mean, this video explains the activity as, I mean, not the activity, the mechanism of action of T cells. Then there is called as primary and secondary immune response. Primary immune response means once a bacteria or virus first entering, like chickenpox. Chickenpox first enters into my body or my B cells, T cells don't know about such a virus. So they will take some time to understand this virus to then develop into the activated one and then also produce antibody against this virus. But the second time, and then at that time they will keep some of the cells, activated cells, into memory cells. So second time chickenpox virus enters my body, my that memory cells will be soon activated. They will immediately recognize, oh, this virus has come some years before. Now I have the pattern. So now the antibody production or the cells to get activated, the T cells to get activated, it won't take much time. In very less time, it will happen. So the primary response, there will be a time delay and it is due to the time that is required for the selection and expansion of that specific T cells or the B cells and the time required to synthesize antibodies. It will take around 10 to 17 days actually. But then at that time, some of the cells get differentiated into memory cells, which will remain like that. And the memory cells are formed by the T cells also. And when the secondary response come up, because the memory cells are already there, they will quickly understand and they differentiate into plasma cells. They don't have to go into that initial process of expansion and all now. And they produce antibodies, which is very quick and the infection can be destroyed and removed very easily. So the secondary response when compared to the primary response is extremely fast. The same with the T cells, it also will become the memory T cells. It's the difference between that, which I have already told you. You can watch these activities in between. Then there is immune deficiency disorder. If there is some deficiency or the immune mechanism is not working properly, it can result in recurrent infection, autoimmune diseases, and some susceptibility to malignancy. sorry, autoimmune doesn't come over here. The consequences of deficiencies of immune system. Autoimmunity here it doesn't come. So there are some warning signs. Presence of more than two warning signs out of these can result in a primary immune deficiency. So this is a table which shows the immune deficiency and the concerned bacteria that will grow. So we have deficiency, the phagocytic activity deficiency, like neutrophils, macrophages. If all these numbers are reduced and the phagocytosis is not happening, then which type of bacteria infection will be more? So we have Staphylococcus aureus, Pseudomonas cerevisiae, Burkholderia, Mycobacterium tuberculosis, a typical mycobacteria. You don't have to by heart this. I just put it for your information. If it is the problem with the complement mechanism, the alternative classical and lectin pathway, what we told, liver is not producing the protein, the complement proteins. Then which bacterial infection will be the so Neisseria, meningitis and gonorrhea, Haemophilus influenzae, Streptococcus pneumoniae, and this will, I mean, if you know, you can understand these diseases except gonorrhea, all these Neisseria meningitis, Haemophilus influenzae, Streptococcus pneumoniae, all these can result in meningitis in children. So this is in that way it is little important. And if it is the deficiency with the T lymphocytes, these are the bacteria. And if it is antibody or the B cells that is deficient, this will be the bacterial infection like that. Phagocyte, if it is reduced, the fungi affected, and the T lymphocytes, which are viruses and protozoa, we already learned it is not the antibody that is more important, but the T lymphocytes. So if it is the T lymphocyte that is deficient, these are the viruses affected, CMV, Epstein-Barr virus, herpes zoster virus, etc. It's how you read that table, not too that important. Then we have autoimmune disease, where the immunity is hyper exaggerated, or they don't recognize their own self antigens and act against them. About 80 types of autoimmune diseases are identified. The cause is actually unknown. They give some explanations that the training for the T cells and the B cells were not given properly during their maturation, but still they are just explanations, not confirmed reasons. So it can be SLE, one example. Other can be celiac disease, rheumatoid arthritis, Graves' disease, diabetes type 1, Addison's disease, pernicious anemia, and psoriasis. In general, the common symptoms of AI diseases, almost all the autoimmune diseases will be fatigue, low-grade fever, malaise, muscle ache, joint pain, rash on different areas of the skin. There are several structures that are commonly impacted by autoimmune disease: blood vessel, conductive tissue, joints and muscle, red blood cells, skin, and endocrine glands. And mostly all these autoimmune disease usually can be present in groups. So if the immune cells are active or destroying one type of cells, there is a probability that they can be acting against some other type of important structures of the body. So the same person may be having one or two type or even more type of autoimmune diseases. So a SLE person, he can develop rheumatoid arthritis also. A diabetes patient can also develop. Like that, autoimmune diseases can be existing with other autoimmune disease. Then we have the hypersensitivity, where the immune system is hyperactive. It is producing four type of reaction. The first three are antibody mediated. Last one is cell mediated. And type 1 is the most important one. It is immediate hypersensitivity, or what we say as the allergic reaction. Even type 4 is actually hypersensitivity, but it is delayed hypersensitivity. It takes the reaction 48 to 72 hours to come out. So the type 1 hypersensitivity, what you usually have, the food allergy or certain animal or the environmental, the dust, mite, pollen, people start coughing or sneezing at that very moment when they are exposed. That comes under type 1 hypersensitivity, which is an immediate reaction. So the thing is, initially there is a sensitization phase. You are exposed to that particular allergen for the first time. You are going into a garden or something, you are getting exposed to a particular type of pollen, the body get activated, antibodies are produced, and it will be IgE variety that is produced. And then they recognize the antigen they produce, and some antibody produce IgE. It will remain in its memory form in the body itself, and this IgE will actually go and combine with the mast cells, and then they are waiting. The second time, so this time, no much serious symptoms comes up. After eliminating this pollen that have entered into the body, the IgE is now combined with the mast cell and waiting. The second time you are going to the same garden, or somehow you are going to get exposed to the same pollen, the pollen enters into the body. In the body, there is mast cells, the basophils. Mast cells, as I told you, it is in the skin, in the gut, etc. So, and basophils in the circulation. So, you inhaled some pollen. The basophils are the basophils in which this IgE is specific. And this is not happening in every patient, only that selected susceptible persons we can see. And then this people, I mean the pollen entered, and the pollen at that time the specific IgE now bound with muscles is like, oh, you have come, I'm ready, and they do some this antigen antibody complex are formed, like antigen, the IgE combined with that pollen, and immediately that muscle or the basophil get broken. And when they are broken, as I told you in that initial picture, all the preformed enzymes, especially histamine, will be released. And that histamine is going to cause the vasodilatation, some edema, reddishness. According to the site that is affected, the symptom will change. So that is the basic allergic reaction. What I told in a very short form is being very nicely explained in this video. So according to the site, it will change. If it is nasal allergy for someone, it will be the rhinitis or the hay fever. If it is eye, then there will be reddishness of the eye, a little bit swollen, conjunctivitis, etc. Sometimes it can be on the skin, then erythema or hives, urticaria that will be formed. Then soft tissue angioedema, especially in the pharyngeal, nasopharyngeal region, the throat region, it can get edematous. Then the person may go into even death condition. Then pulmonary reaction, if it is in the lower airway, that is the lungs that is affected, it can result in allergic asthma. Then if it is whole body affected, we call it as an anaphylactic condition. So if it is localized like nasal, ocular, dermatological, single place, it is called as atopy. If the whole body is affected because of this allergy, then it is a life-threatening medical emergency, and that condition is called as anaphylaxis. Then we have type 2 hypersensitivity, which is actually cytotoxic. Means some antibody will be produced, and this antibody can destroy certain cells. And usually this hypersensitivity reaction we see in hemolytic anemia and also acute blood transfusion reactions. We have the type 3 hypersensitivity reaction. Here, antigen and antibody will be forming complexes, which we call as immunocomplexes. And then they actually had to get eliminated from the body or eaten by the phagocytosis, but that doesn't happen. Instead, this immune complex, the antigen antibody complex, it get deposited in kidney, synovial joint, etc., especially the basement membrane. So resulting in destruction of the basement membrane of the kidney, which means resulting in glomerulonephritis. It may also get deposited in synovial joints, resulting in rheumatoid arthritis. So rheumatoid arthritis is actually a type 3 hypersensitivity disease and also an autoimmune disease. Then type 4 hypersensitivity, it is actually the cell mediated immunity or delayed type of hypersensitivity. Here there are no antibodies, but it is the T cells that is involved. The best example will be contact dermatitis and the tuberculin and lepromin test. You remember the tuberculosis, we gave that a tuberculin injection and then we watch after 48 hours and lepromin after 272 hours and see the reaction. And lepromin test, we also do it after 21 days. So that are the delayed hypersensitivity. And contact dermatitis, like it can result from nickel, poison ivy, household cleaning products. Many housewives do have this problem. So here there will be redness, itching, swelling, and heat. And this delay in hypersensitivity is due to the delay in transporting Th1 cells or T helper type 1 cells to the site of infiltration. These were the two main. The other thing, I'll just show you this PPT, not getting into the details. Do message to Mr. that to take the class little later. I'm sorry, because now it's Farha's class also going on just a little time before to your class. That's right. Are you seeing the PPT now?
Yes.
Okay. Where is the PPT? So the tools and techniques of diagnosis, the third section. It's mainly about the diagnosis. I didn't go into detail. I told you, and I was not planning to take this class for you. How much questions? And I think you are actually studying this one, the diagnostic procedures in study of man and disease, study of patient and diseases. And so I didn't go for that. So just indicating the importance of diagnostic because we have done the screening. We need to know something about the diagnostic procedures. So some essential diagnostic, we starts with the physical examination, the observation, palpation, auscultation, and percussion, and try to diagnose. Then we go for the laboratory test, the basic one where we go for the blood test, the routine blood examination. We can go for the urine analysis for the glucose, protein, blood cells, pus cells, etc. Then the imaging techniques for the X-ray, CT scan, MRI, then USS scan we can do. Then we can go for the biopsy where we will be taking some tissue samples and then watching it under, mostly if it is done for some growth to understand whether there is any cancerous cells that is present. Then endoscopy to view inside what is happening. So we do that for digestive tract and also for airways. We have the electrocardiogram to measure the electrical activity that is happening in the heart. Similarly, we have EEG to do the electrical activity in case of brain. Then we have the X-ray and also X-ray with the help of the compute. It will be more efficient if we do this computer tomography where the X-ray are combined to give a cross-sectional images. It will be more clearer. Then MRI is the where we use the magnets and radio waves to generate detailed images, and then also ultrasound. There is nuclear medicine, especially the positron emission tomography and SPECT also. Then the genetic testing or the molecular, the polymerase chain reaction, NGS, point of care testing, and some clinical scoring system, especially in comatose patient, where we use Glasgow Coma Scale, uh, biometric and wearable devices like smartwatches. So from a distance also we could monitor the vital signs. Telemedicine and remote diagnostics, the artificial intelligence currently developing. When all these are going, we shouldn't forget the basic thing, the medical history. From medical history itself, we will get a lot more clue. Because when we started with the physical examination and we ended with artificial intelligence, but above all of these things, the basic communication with the patient, the medical history, and gathering information from that patient is more important in any diagnosis. So this is only about the tools and diagnostic. And the last one is about communicable diseases, I think. One minute. So this is the last section, epidemiology of communicable diseases and new techniques of diagnosis. As I already told you, it's for the MQA purpose. I have prepared this. So it has got 46 slides and all. I don't have to say you what is communicable diseases. Uh, just go through this. I mean, not for the exam, just for your information. So the communicable diseases with direct contact transmission. Examples for skin to skin, respiratory droplets, sexually transmitted infection. Then transmission, if it is via respiratory droplets, the examples for that. The fecal oral transmission, then the diseases, hepatitis A, cholera, vector-borne transmission. So all our dengue, malaria, etc. will come. Then zoonotic transmission, especially the COVID-19 because it originated from bats, and then rabies. Then the vectors that are involved, a global impact about the communicable diseases and its prevalence, its economic and social consequences, the ways of preventing it via the means of vaccination, the herd immunity, proper sanitation, food safety measures, role of public health campaigns, and also community engagement. There's a subsection in that is emerging and re-emerging, which we have already dealt, and some diagnostic techniques where we say about microscopy, bacterial identification, the gram staining comes the parasitic infections, its detection. The culture technique, now you should be knowing what is culture technique, the bacterial culture, the fungal culture. Then based the antigen based test, the blood test that we do, to diagnose the antigen or the molecule that is present inside the pathogen. So we have the rapid antigen test for influenza and respiratory syncytial virus. Um, then about the polymerase chain reaction, which you will be taking actually. The NGS in detail. Is anyone doing this? I mean, PCR you are doing. NGS, is there in your list of assignment? I mean, is someone presenting NGS? No. Okay. Even I'm not sure. NGS, I thought it might be the point of care testing. It is not a different test, but where we are the at that particular area the test being done, which means POCT brings diagnostic testing closer to obtain test result quickly and efficiently within minutes, like in case of COVID-19, when we did that, not RT-PCR, the other test, the antigen sensitivity test, that was a POCT. So some examples being given over there. Then this is CRISP R Cas system. Uh, this is actually coming under your category, I think. It's using RNA molecule to target and bind to specific sequences of foreign DNA or RNA. Digital health technologies, where we use the mobile and all the other things. Yeah. In case if some of you are doing PCR, yeah, it's over there. NGS and also CRISPR or CRISPR. You can just refer this. Otherwise, for exam based, I'm not asking any of these questions. I told you it's just for the purpose of MQA documentation. Have you taken? No, yeah, one is enough now. We need so many. Okay. So we will conclude the chapter 4 now. So if you are done your presentation, let me know when we can do the presentation. Is it next week or after to that? Just let me know. And that's all from my part. So study well for your exams. As I told, I know I was just skipping through the last PPT health. As I told, I'm not going to ask you any question from that. Do you want that PPT actually, or just you need only sensitivity and immunology alone?
You want.
You want,
Yes.
but don't spend time for your exam. Just keep it for your future somewhere if you want to. For only for exam, don't waste your time on that. It's getting recorded. God knows anyone is hearing that or not. So, so you are taking. You have already sent me the this one, right? What is that screenshot?
Attention, yes.
Okay, so thank you all. Let me know when you
Okay.
want the presentation. Okay.
Okay. Okay, thank you.
Thank you.
Thank you.
Thanks. Thanks.